everybody. Welcome to Decoding DX, episode number 6, Diabetes Wellness Visit. Just so that everyone knows for sure, we are all M4s with the exception of Dr. Brunkow, who happens to be on this call as well. And thus, this is going to be an educational purposes only session, not to be used for medical advice. No doctor-patient relationship is being formed. We'd love for you to check out our website, check out our YouTube channel to see some of the other stuff that we put together. But that being said, we're going to go ahead and get started. And thanks to Justin Kugel for editing and doing the post-production for us afterwards. Kelsey's going to be doing our scribing today. Dr. Brunkow, before we get started, are you okay with us calling you Mollyanne?
Yes, please.
Wonderful. Tell us a little bit about yourself, something about what you love about medicine, and then something that you love that has nothing to do with medicine.
Okay, so I am a PGY-2 at John Peter Smith Family Medicine program in Fort Worth, Texas. I was born and raised in Topeka, Kansas, medical school at KU Kansas City. I hope to return to Kansas to practice full spectrum family medicine. And I really love like continuity with patients. Today in clinic, I saw a mom and baby who I delivered. Mom is 17 and is rocking it being a teen mom, and baby's doing great too. And that's one of the most fulfilling things in the world for me, to get to be a part of people's lives and know them and also take care of them medically. Outside of medicine, I really like being outside and going on walks, and my neighborhood here in Fort Worth has a duck pond. So I really love walking to the duck pond and feeding the ducks.
That's amazing. I hope we don't hear him going quack, quack in the background. So, all right. Well, our first patient, I know we just finished up our outpatient clinics, but quick call, the nurse said there's another 4 people walking in. The first one is a man named Mr. Carl Kunter. He's a 62-year-old male city administrator with a past medical history of hypertension, hyperlipidemia, and prediabetes, who's presenting for his annual wellness visit because his insurance told him to come in. So just a little bit of information about Mr. Carl Kunter. His heart rate was 73, blood pressure 132/83. BMI was a little elevated, 31.2. A year ago, his A1C was 6.4%, but today he got his labs done last week and it's 6.5%. We also did a lipid panel a week ago and did his labs. It was within normal limits. Previously, he had dieted back in 2019. He did some carb counting, some restriction, less than 100 grams a day. But after he lost some weight and started feeling better, he decided to go back to his regular diet because he'd had some success and then regained the weight. He's been physically inactive since his gym closed for COVID-19, and then he's also had some increased stress at work as a city administrator during this time. But with his A1C, he's a little scared today, and he'd like to stay off medications if possible. And so our first question that we have, I'm going to throw it to you, Brianna. How would you classify Mr. Carl Kunter today?
It's been a hot minute.
Yeah, so with that A1C of 6.5%, I think that is the cutoff for when we say diabetes. So I'm trying to remember off the top of my head if the technical definition is greater than or equal to, or if it's just greater than, because technically if it's greater than or equal to, then he's not quite there yet, but I think we can confidently say that he's right about there. So I would say he's in the early stages of diabetes.
Yeah, very good. And then do you think he should recheck his A1C?
Today, no. The A1C is an average of the kind of the blood sugars over the last 3 months or so, and so rechecking it should give you about the same number, just within the error from the lab. So it'll be about the same. So I don't think it would really change management at all to recheck it, unless we were to recheck it in a few months from now.
Yeah. And then Mollyanne, Mr. Carl Kunter wants to stay off the medications. How would you approach this conversation with him in the clinic, given his desire to stay off medications, but his new diagnosis of type 2 diabetes?
Yeah. So, and I think you are actually going to get into this more in one of the later cases, but the first medication, if I were to start this man on a medication, would be metformin. And there's actually a mortality benefit to metformin. It's a really good medicine. And so I would have the conversation with the patient of, if you were to start a medicine, we would start with metformin. It's a really good medicine, and that's not the end of the world. And he's probably going to say no, and that's okay. It at least prepares him for the next step. And then I would say, okay, you can go back to carb counting. Basically, you have to eat fewer calories one way or another. You need to become physically active again. And another thing that you could offer to him, if he's a fairly healthy person, is there's some good evidence for improving insulin resistance with intermittent fasting. Maybe he doesn't want to count carbs every day. Maybe he'd rather do intermittent fasting. But you can kind of use lifestyle changes with the incentive of, if you can do lifestyle changes, you can probably stay off medicine for a while.
Yeah. So clarify what you mean by intermittent fasting for me. I know there's a
Yeah,
ton of
so
different
there's
definitions.
Right. So there's several different definitions. Ones that tend to have better evidence is doing at least 2 days a week of very restricted calorie intake, like 500 calories in a day or less. And there's another form of intermittent fasting, which is limiting calorie intake to several hours in a day. That one doesn't have as much evidence, although it's probably easier for patients to do. But actually going for a length of time with a very low or no calorie intake, it tends to have some evidence that it increases insulin sensitivity. It's not for every patient. Carb counting is probably a easier accepted way to improve his insulin sensitivity. But one way or another, he needs to have less carbs, less processed sugar.
Yeah. So Brianna, you just heard quite a few recommendations that you would give to, that you could give to Mr. Carl Kunter. What would be one of the ways that you would approach teaching him and explaining some of those recommendations?
Yeah, so I would say, I think just really having a really open conversation with him and saying, in your current state, of life, of work, of, your gym being closed from COVID, how do you feel about the likelihood that you'll, be able to do things like maybe exercise some more? What is the idea of carb counting or calorie counting or intermittent fasting? How does that strike you? I mean, I know some people, like, food is a really important cultural thing for a lot of people. And so that can be like really devastating to their quality of life if you're to suddenly, tell them they have to change their entire diet. So I think really asking them, what sounds good to you? Because ultimately, diabetes as a diagnosis can be very life-changing as far as their day-to-day life. And so I would want to make sure that this patient is fully on board with what the plan is and feels like he had a say in what we decided to do, because I think that also make it much more likely that he would adhere to whatever, the decision was made, that would hopefully get his blood sugar down and maybe bring him back below to that pre-diabetes level.
Awesome. Thank you. Yeah, I think patient ownership of the decision is really an important factor in whether or not the changes actually get made, that they feel like they were the ones who made the decision in the clinic. And then Mollyanne, you mentioned earlier some processed sugars that you cut out. Immediately I think about sodas. Are there any other processed sugars that you would advise a patient to cut, nix, or restrict?
I'm glad you asked that question. So this is where using easy to understand patient words is really helpful. I ask patients, what do you drink? And then, kind of walk through in a day. Are you drinking juice? Are you drinking soda? Are you drinking water? Basically I tell them they need to completely stop drinking sodas, except for one, like for a special occasion sometimes. Stop drinking juice, and talk to them about how that's very sugary. It's basically a lot of sugar intake, and eating a whole fruit is much better for you with the vitamins without the intense sugar intake. And then I talk about limiting sugars, cakes, ice cream, candy, things that we know have sugar. And then I talk about limiting things that turn to sugar quickly in your blood, We would say starches, but patients are thinking sugar and diabetes. So I talk about bread, rice, pasta. I have a lot of Hispanic patients, so I talk about tortillas and potatoes. And then I talk about serving sizes. A serving of pasta is the size of my hand, and I have very small hands. And so a serving of pasta is not a plate of pasta. It is a very small amount of pasta. And all of those things turn to sugar very quickly in your blood, and you should be eating very small amounts of them.
Awesome, thank you. Scientific index for that would be the glycemic index of the food. But as any of us could expect, the second that you decided to say glycemic index to a patient, their eyes would probably glaze over and they likely would not understand. So, and then just kind of one last thing. So Mr. Carl Kunter's in the clinic. He doesn't want to start metformin. We explained intermittent fasting to him, and he really said, I like to eat. I don't want to take a day or 2 days or a meal a day where I don't eat. I'd like to try the carb counting again. How many carbs should I eat, Doc? Mollyanne, how would you answer that question?
I don't know. I'd have to look it up.
That is a wonderful answer. This was actually a clinical question that I had prior to today, and the data is not overly precise. So there's a really good reference article that we can put in the notes. It came from a journal of nutrition, and it defined different types of low-calorie carbohydrate diet. Most of the best data is on very low, which would be less than 50 grams a day, but that's pretty extreme. That basically is what the ketogenic diets or the Atkins diets have proposed. And there's some evidence showing that as well as less than 130 as well. And this might be one place where the art of medicine comes in. And you say 130 might be ideal, 50 or might be okay, 50 would be best. What do you think you can do? And so in our clinic, when Mr. Carl Kunter came in, he decided to go back to his 100 a day threshold and see what he could do from there. And so I guess the follow-up question is, we saw him a year ago. His A1C was 6.4. Now it's 6.5. He wants to stay off medications. What kind of follow-up would you like to see from him? How soon do you want to see him back?
Could you address that to me?
Yeah.
Sorry, I didn't catch that. I would want to see him back. Sorry, I didn't catch. Are we starting him on a medication?
We are not. He wants to avoid it like the plague.
So he wants to do diet and stuff like that. I would want to see him back depending on his availability. I know for some patients, it's a really big deal to get off work and come into the office. So I would talk to him about that and see what sounds reasonable to him. If he's able to get back in 2 weeks, I think that'd be a good, gauge of how is the diet change going. I wouldn't want to push out too long and risk having him kind of, give up, this is too hard or something like that. But that being said, if he has a job that makes that really tough, I wouldn't fight too hard if he wasn't able to get in until like 4 or 6 weeks.
Mollyanne, when would you like to see him back?
So I think some of it would be based on his willingness to change. If I think that he's actually going to do a good job cutting carbs but needs a cheerleader, I would do like Brianna said and have him back in a couple of weeks. If I think that he's isn't going to benefit from me being a cheerleader or isn't going to make a significant change, I would even push this out to a year. I think it's reasonable to say your hemoglobin A1C has not significantly changed in a year. Come back in a year and we'll have this conversation again.
Good. I think that highlights that the right answer for when do I see somebody again is quite malleable. So we have 2 questions from the chat that I want to hit before we move on to our next case. One is trying to get him to switch his diet up, a good starting place for reducing soda. I'll field that one. I think it's a great spot. Honestly, I would lean towards saying that any patient with diabetes should not be drinking soda. And if they're very resistant to cutting soda, switching them to a non-caloric, non-absorbable sugar would be the best option, and maybe the first place you could get them to start making a change. And then the second one, question from Malika that I'll pass on to you, Mollyanne. If you did see them back in 2 weeks, would you want any labs?
That's a good question. I think we already have lipids on this guy. I would consider getting a TSH. And in case, I tend to do that with patients who are overweight. The lipid panel is good. I would consider getting a BMP as well to check his creatinine, I think is the other one. You also can get a urine microalbumin creatinine ratio, which would be helpful if we're going to really call him diabetic. And so I may have him do that if he's okay with giving us a urine sample.
Cool, thank you. All right, so we're gonna move on to our next case. Mr. Carl Coon tried to run for work. He's now out of the clinic. He's going to come back and see us in a couple weeks. So then the next nice elderly lady who comes in is named Betty Sales. She's an 82-year-old female truck driver, and she has a past medical history of hypertension, hyperlipidemia, diabetes, and peripheral neuropathy. Who's here in clinic today for a 6-month follow-up. She just got back from driving her truck back from Oregon, where she was dropping off some RVs. She's a little tachycardic, blood pressure to 104, blood pressure is 108 over 64, BMI is 32.5. She tells us that her morning sugars are generally in the 130s to 140s, occasionally in the 160s to 180s. Her previous A1C was 7.9. She continues to have some numbness and tingling in her feet. She does not have any visual disturbances. She's tolerating her medications well, which include glimepiride 1 milligram every day and metformin 1,000 milligrams in the morning and at night. And Betty Sales is really motivated to keep her A1C less than 8 and to stay off insulin so she can continue to drive trucks for her work. And so our first question that she had and that we have is, how did her fasting sugars or average blood sugars correlate to her A1C? Mollyanne, I'll pass that one to you.
I think you have the wrong set of questions for this patient. Oh, no, wait, I have the wrong one. Sorry, looking at the wrong questions. Yeah, so there's a chart that you can look up for how your morning, like your average blood sugar generally correlates to the A1C. But in general, if a person's fasting sugars are fairly well controlled, I would expect their A1C to be well controlled. To the extent that often my patients don't get labs before they come, but I'll make adjustments based on what they're telling me that their fasting sugars are.
Awesome. So what would you expect for her A1C to be today? We'll do the two scenarios she gave us. So her fasting's 130s to 140s, or her fasting's 160s to 180s.
So I'm going to pull up a chart. Just Gestalt, I would say that it's probably the 7 to 8 range. And in fact, when I pull up a chart, so if her sugars are what was the first range? 130 to 140s.
Mm-hmm.
So that would be like between a 6 and a 7. And the second one was 140s to 150s.
160s, 180s.
160s to 180s. That would be between like a 7 and an 8.
Cool. Very good. I think that's a great example of using your friends, namely I assume Google in this case, to pull up clinical data that you can actually apply. And from our chat, Jacob had a really good point. 6% is about 120, 30 increase with each 1% increase of A1C. Thank you, Jacob. And so what would be going on? So you pull your A1C. What if it isn't correlating? What are some things that can cause an A1C to not correlate to the sugars that they're being reported?
Is that another question for me?
Mm-hmm.
Yeah. So kidney disease is the big one in this. Someone that has renal disease is likely to actually see a decrease in their hemoglobin A1C. And in this case, it is not a good thing. It means that their kidneys are dying. And then the other is blood loss. I actually saw a hemoglobin A1C that was 3 something in someone that had an acute anemia. You think about it, it is looking at the glycosylation of the blood cells. So anything that's causing really rapid blood cell turnover will artificially lower hemoglobin A1C.
Yeah, that's very true. And it kind of applies the other way too. Anything that artificially elevates blood cell lifetime will elevate A1C. So either if somebody doesn't have a spleen, or if they have a condition where they're unable to turn over red cells. So then, Brianna, a couple questions on this patient's drug history. They're on glimepiride. How does this drug work, and why might this patient be on this medication?
Yeah, so if I am not mistaken, that is a sulfonylurea. That the way that it works is kind of like tricking the pancreas into releasing more insulin on its own. So it's kind of a workaround to giving insulin. So it's kind of like a pseudo insulin because you're just kind of tricking your body. And so my guess would be why this lady is on glimepiride is because as a truck driver, she would lose her job if she was on insulin. I know even just in my family med rotation in third year, I had multiple patients where that was an issue where we would have maybe preferred for them to be on insulin, but they would have lost their job. And that just has to do with the risk of hypoglycemia if they're driving like a semi. That's kind of just one of those things that we come up against. And I've had many patients and patients at the hospital, admitted to the hospital for that reason as well, where they really need insulin, but they just can't with their job.
Yeah. Yeah. And it is a powerful tool for motivation. So with Betty Cell's history, she has kind of the standard story of some heart disease as well as some diabetes. Do you have any concerns, either Brianna or Mollyanne, with this patient's current medication regimen?
So I first of all, the sulfonylurea will say that most of my patients were placed on that are still on a medicine like glipizide or glimepiride, were placed on it a long time ago and are on it because it is a very cheap medicine as well. And so patients that are underinsured or uninsured are often on this medicine. We have really good newer diabetes medicines that actually have a good chance of reducing her risk of a heart attack or stroke, particularly of a heart attack, that I would much rather this patient be on. And I also worry a lot about hypoglycemia with sulfonylureas because that is a pretty big risk with them. So this patient would be a good patient to talk about. Let's try one of the newer diabetes meds that has a mortality benefit to help reduce your risk of heart attack or stroke.
What are some of those medications? How do they work?
Yeah. So do you want me to field this question or someone that's had pharmacology more recently?
Go ahead and field it, and then we'll fill in the pharmacology details as needed.
Yes. So a GLP-1 has good evidence for improving cardiac outcomes and also can help with some weight loss, which glipizide or sulfonylurea cannot do. And also a SGLT2 inhibitor can help with managing hyperglycemia without causing hypoglycemia. It also has good cardiac evidence. Those are my two favorites right now, and they're starting to become a little bit more affordable where a person with Medicaid or Medicare or even underinsured can likely find one way or another to get that.
Yeah, and I find it interesting. Some of the new requirements for diabetes meds to be approved is that they show a benefit in cardiovascular outcomes, which is one reason why you're seeing these studies come out that have the cardiovascular wings of these diabetes trials that are not just looking at some of the typical diabetes-related outcomes that previous literature had looked at. Another benefit for some of these medications that can be available to patients is the Medicare 340B program, which is available generally through primary care offices, and also either in like federal qualified health centers or in rural locations where there's a reduced drug price that's available on the basis of a Medicare arrangement with these novel therapies in order for them to be on the market. Unfortunately, that's currently trying to be removed by pharmaceutical companies, even though it does provide a great service for patients who wouldn't be able to afford the medications otherwise. So just kind of to wrap up a little bit of this case, so if we're looking at cardiovascular risk for her, which she definitely would be at, we would want to consider the GLP-1 or SGLT2 inhibitor. But given the morning sugars in the 130s to 140s, we're not too concerned that her A1C is going to be greater than 8.
Yeah.
And we're not looking at starting insulin at this time. So Betty Sales should be able to continue her work as a truck driver. So.
And I know we talked, kind of glossed over the pharmacy or the, like how the drugs work. I will give you the nitty gritty of how I think about it in my mind that helps me remember some of the side effects. The SGLT2 inhibitors make you pee out urine or pee out glucose, but you can't pee out too much glucose because eventually your kidneys say no. So that's why I remember they are not too bad with hypoglycemia, and they do help with weight loss because you're getting rid of some of that. And then the GLP-1, something with stomach hormones that's magical that makes you eat less and lose weight is kind of how I remember them, also with a lower risk of hypoglycemia because it's not affecting insulin secretion as much.
Yeah. And then some of the major side effects for them kind of go along right with their mechanism of action. Increased sugar in the urine increases risk of infection. So many of the side effects of the SGLT2 inhibitors are related to infectious causes, or also the rare DKA, which we had a case on a couple weeks ago.
Yeah.
And then with the GLP-1s, one of the main side effects that patients stop it for is nausea, because it causes early satiety, early fullness, and then any food in the stomach then causes them to feel like they shouldn't eat anymore. And so if you overeat on them, or if you have an overreaction to them, then you can have some pretty significant nausea that causes people to stop taking them.
I actually have a patient in the hospital right now with a groin infection that was just random, kind of a labia majora abscess. And we were consulted to help with her diabetes. And I'm like, well, you would be a great candidate for an SGLT2, except that you've just had an infection in your labia majora. So let's do a GLP-1 instead.
That's a perfect clinical tidbit there. So
quick, Ben, real quick. One little note on all those super fun meds that I am totally on board with as a future internist with the cardio protection, but I do not know of any hospitals that have them on formulary. So if you have a patient that is on these medications outpatient, when they come into the hospital, you typically will have to, maybe add a correction factor of insulin or something for that while they're in the hospital, because they cannot get these in the hospital.
So that's a really relevant detail there. So we'll go ahead and move on to our third case. Thank you, Brianna. This is Inna Salim. He is a 58-year-old male factory worker with a past medical history, again, of hypertension, diabetes, and depression, who's presenting to clinic today for medication review. He's coming in late because he just got off his shift. He has no concerns today. His A1C was 10, and he's feeling really well with a blood pressure of 162/80. He's currently on nine medications, but he's only taking his Cymbalta for his depression because he feels kind of bad if he doesn't take it. He gets a little bit of a headache. Taking it kind of clears away the headache and some of the mental fuzziness. Mr. Salim has an irregular work schedule. He covers all 3 shifts at the plant each week, but on different days. So on Monday, he works first shift. On Tuesday, Wednesday, he works second shift. And then on Thursday, Friday, Saturday, he works third shift. Previously, he was given some semaglutide samples, which is one of those GLP-1s that we talked about. But he was unwilling to perform the injections. Currently, he's prescribed metformin 1,000 milligrams BID, but he is not taking it as prescribed, as well as with the semaglutide. And he has a normal diabetic foot exam today, and his urine microalbumin was less than 30 milligrams, which is a good number on that urine microalbumin. So with a patient like this who comes in feeling well with a blood pressure in the 160s, A1C in the 10, I've heard of hypertension called a silent killer, and I've heard of diabetes also called a silent killer. Brianna, why might both of these illnesses be called silent killers of our patients?
Yes, so these are the big scary ones, because you oftentimes don't feel them or see any evidence of their damage until it's kind of in the end stages. So with both blood pressure and diabetes, they can be very harmful to the kidneys, for example, and also to the blood vessels. But oftentimes you don't feel those things until, suddenly I've had many patients present to the hospital in overt kidney failure, or with severe high blood pressure that they just don't feel because their bodies are used to it. No matter how used to it your body is, it still can reach a threshold that can become very, very dangerous. And unfortunately, at those times, often some of that damage is irreversible.
Yeah, it's kind of the whole you can boil a frog in a pot, but you can't throw a frog in a pot of boiling water analogy. So, Brianna, given his 9 medications he's taking, only taking Cymbalta, what challenges might he be facing in taking these meds?
Yeah, so I know with people that are on rotating shifts and having just very irregular schedules, it can be very hard to adhere to, some of these medication regimens where, it's this one at this time of day, this one at this time of day, this one at this time, and it's just kind of hard to keep track of, especially if they're, at work and doing something like at a factory where they're not able to, go inject themselves or, go to a med vax and take it at a certain time. And so my guess before talking to this patient would be that just the regimen of that many medications is just too complicated for him to be able to handle with his kind of hectic work schedule.
Yeah. Mollyanne, how would you go about helping him with it?
So I would start with little steps. He presumably maybe has metformin at home. Let's get him to try to take the metformin twice a day. And, take it in the morning-ish or at night-ish. It doesn't have to be exact. Just do the best you can. And then I would probably put this guy in an SGLT2 if we could figure out how to help him afford it. Maybe he's got insurance through his employer. That would be great. And again, we're not aiming for taking it at exactly the same time every day. We're just trying to get as close as possible. I'd really like an SGLT2 because it tends to have some diuretic effect and can help with blood pressure as well. And then I probably would choose one blood pressure medicine for him. I really like lisinopril because it can help protect the kidneys. So not specifically lisinopril, but an ACE or an ARB, it's certainly reasonable to start with an ARB if you're concerned about angioedema, and insurance is starting to recognize that you don't have to start with an ACE first. So get him on an ACE or an ARB. And again, take it when you can. We're not looking for perfect. We're looking for better than what you're doing now. And if 3 medicines is too much for him, then, we'll start with the metformin or something like that. And this is one where we're probably not going to get his hemoglobin A1C below 7, but hopefully we can help him stop running around with a hemoglobin A1C of 10.
Yeah, that's a great point. And hopefully get him to stop running around with the blood pressure in the 160s. I really appreciate how you kind of go at the art of medicine there, of we're not looking for perfect, we're looking for better than yesterday or better than last week. With his work schedule, where some nights he's pulling all-nighters so that he can stay up for his next shift, some nights he's sleeping 12 hours during the day and then up all night, how do you address these morning, evening dosing schedules whenever somebody has irregular day-night regimens?
Most people wake up at some point and go to bed at some point. So a lot of people brush their teeth twice a day. So as whatever time you're waking up, whatever time you're going to bed, take your medicine then. Fortunately, with diabetes and blood pressure medicines, we usually can get away with not having to have them with or without food specifically. And I would choose meds that you can just kind of take whenever. This would be a bad patient to give clonidine, which has like rebound hypertension if you don't take it. I would give him meds that if he's going to miss some doses, it's going to be okay.
Awesome, thank you. And then he doesn't like the injections on a semaglutide. Let's assume he's taking his metformin well. We talked about the SGLT2 inhibitors as another option. If he doesn't like the injections, what other medications are available for him? Brianna, what are the ones that come to the top of your mind?
Sorry, things are getting a little hectic in the workroom here. I'm gonna have you pump that to Mollyanne.
Okay. Mollyanne, non-injectable medications that come to mind.
Yeah, so if we wanted to keep him on a GLP-1, whatever the generic for Victoza is, I believe is or no, that one's an injection. There's one GLP-1, and I would have to look up the name, that you can take orally, which may be a good option for him. I really like the idea of an SGLT2 for him. That's kind of where I'd start, because they have really good evidence, and they're not going to cause him hypoglycemia. You know, I don't want to put this guy in a position where if he gets messed up on taking his meds, he's going to end up hypoglycemic at work. Yes, thank you. Semaglutide.
Mm-hmm.
Yeah, that's it. So I would probably not get too creative with this guy, because there's really good evidence-based diabetes treatments that he's likely to be able to afford if he has some insurance, that have good benefit that we haven't tried yet.
Yeah. Awesome. Perfect. Well, I think we've hit a lot of good stuff for this guy, of narrowing down his med list, simplifying when he can take some stuff. One take-home point for me out of this case is that medications on a med list may and often are still in a pill bottle. And so in his case, he has pill bottles upon pill bottles at home that have not been taken, and that if you only ask, what meds are you taking, or what meds are on your med list, or just look at the med list in the EMR before you go into the patient room, you'll miss the patients who are prescribed a medication and not taking it. And that's the explanation for their A1C greater than 10. They don't need additional meds. They just need some of the meds to actually be put in a form or taken off so that they can take the ones that they have. So then our last case of the evening, before we get to go home and finally have some supper, is Samantha, who goes by Sam OG. She is a 62-year-old female school cook. Her A1C was 9.6% 3 months prior to this visit, and she's coming back for a repeat A1C evaluation. She had a lab scheduled last week to take before she came in, but she forgot to get them drawn due to her work schedule. But she says her morning fastings have recently been between 170 to 200. But she found that she was waking up kind of with like sweats, feeling a little funky, symptoms of hypoglycemia that she noted at 2 to 3 a.m. every morning. And she decided to decrease her Decoding, her long-acting insulin, from 50 units to 40 units. Since then, her morning fastings have been in the 130s to 150s. She's really perplexed why this has happened. And currently, she's also taking metformin 500 BID and Aspart, which is a short-acting 26 units with meals, and that's on a sliding scale. Previously, she tried an SGLT2, but she had ketones in her urine and a fungus ball, UTI. And she would like to get her A1C below 9, preferably by doing exercise, but she's currently limited by some back pain. Pretty severe, starts after a block of walking, and generally at work every day between 10 and 10:30. She's seen pain management. She's tried a whole lot of different things: spinal injections, lidocaine patches, muscle relaxants, tramadol, and none of them have really helped or prevented the symptoms. And pain management really hasn't been able to get her back pain under control. She recently stopped taking cyclobenzaprine because it made her too groggy at work, and she uses lidocaine only on days when she feels bad in the morning, because on the other days she doesn't seem to notice it helping as much. And when she feels bad, it doesn't really help, and she still has the back pain around the same time during the day. So there's a lot going on with Sam OG, quite a bit. What she's most perplexed with to start is, why did decreasing her insulin improve her morning fasting blood sugars? Mollyanne, I'll pass that one to you.
Yeah, so it is someone who's had physiology more recently is probably going to be able to explain this better. But basically, your circadian rhythm affects how cortisol is released, which affects how your liver makes sugar. So your liver is paying attention to your glucose levels in your body and to your cortisol. And so avoiding those lows, or avoiding the liver getting this distress signal of make more insulin. And so you're going to have a not this rush of sugar from the liver. When you're dealing with sugars overnight and in the morning, you really have to think about what is the liver doing, because if something weird is happening, it's probably due to your liver signals.
Yeah. And the effect of this is in the name. It's the Samoji effect. CMOG. It's a pretty terrible pun. And so the extra insulin in the PM dosing drops the blood glucose too low, which triggers that cortisol reaction. And this can either occur from having too much insulin the night before or from having too small of a meal. So if somebody has this periodically, you can ask, well, are you eating the same size of meals every night? And if they have meals where they don't eat as much, they take the same amount of night insulin, and then they have this effect, that could be your explanation. Or if they're in the hospital on the same amount of insulin, not eating their meals fully in the hospital because they don't like the food, that can be the cause as well. In her case, she's eating regular meals, and so she just decided to decrease her insulin. It happened to work, which is a wonderful case of a patient taking their dosing into their own hands and having a positive outcome with it. The other one that you can find is called the dawn phenomena, and that's just where you don't have the lows overnight, but you have these elevated morning cortisols or elevated morning blood sugars, and that's due to increased cortisol during the nighttime. Way to check for it's looking at 2 to 3 a.m. To see where the blood sugar is at. If it's low, it's Samoji. If it's high, it'd be dawn. And so we've kind of talked a little bit about the ketones in the fungus ball as being a side effect of the SGLT2 inhibitors, and that being related to the glucose. She had a question about that, but we seem to have already been able to answer it. So really what we want to do is keep her off of additional medications, and she wants to do that by walking, which is limited by her pain. So to refresh what she's tried, she's had lidocaine patches, muscle relaxants. Muscle relaxants are cause her to be too groggy in the morning. She's tried some injections. They haven't really helped too much. And then she also has some tramadol, which finally seems to cut it whenever she takes it in the daytime, whenever she hurts. So Mollyanne, how would you go about augmenting her pain management and trying to get her back to walking?
Good question. So this is literally all of my patients that are old that should be walking have a joint that hurts significantly, that keeps them from walking. So something that's not on her list is Tylenol. Tylenol is safe for almost everyone. 3 grams in normal people, 2 grams in people with liver disease. And even when they say it doesn't really work for me, I tell them, I want you to take the Tylenol first, and then let's talk about other things because it may help a little bit. So take Tylenol, take Tylenol, take Tylenol. I don't know what her kidney function is. And in someone who's been diabetic for a while, who may have some hypertension as well, I always worry about, is there some CKD that I'd want to avoid an NSAID? There can be some cardiac problems with NSAIDs as well. But she may be someone that I could tell, take naproxen or an NSAID sometimes in addition to the Tylenol, but Tylenol is really a safe first bet. In a younger patient, let's say that she was 42, I would be much more pushing the NSAIDs as well. In the chat, we're talking about Voltaren. That's a really great idea. Voltaren gel rubbed on the knee is perfect, especially if we're trying to avoid NSAIDs. I would consider sending her to physical therapy as well. They may be able to do something for the back pain that pain management hasn't done yet either. And then I would talk to her about kind of pacing herself. Like right now, you can walk 1 block, take a rest, and then walk your block back home. And if that's what you can do this week, this is good. The next week, try to walk a block and then 3 more houses. Whatever you can walk, that's good, and try to pace yourself to do a little bit more. And then I would think about other ways to get exercise that may not bother her back as much. If she has access to a swimming pool, that can help for joint pain. If she has access to doing some kind of gentle exercise class at the gym, walking is a really good exercise because you don't need equipment. And as long as you live in a fairly safe neighborhood, anybody can do it. but maybe explore if there's some options in her community that she may be able to do that will take some relief off of her back. And then my physical therapist sister uses the phrase motion is lotion. And I always try to talk to patients with arthritis about this, that even if it's uncomfortable, actually using the joint that hurts can be helpful. Don't overdo it, but motion is lotion, keep using it. And it's important to keep walking.
That may be one of my favorite phrases out of this entire hour. Is that motion is lotion. Definitely needs to be in our teaching points. Absolutely needs to be included. And thank you for thinking about all these alternative options, like places to work out, areas to do some exercises that wouldn't be weight bearing, such as in a pool, and utilizing our other colleagues, such as physical therapists. Often we get walked into my referrals need to go to MD's mode, and our referrals actually can sometimes best be served by going to someone who has a different specialty entirely. So thank you for thinking about that. With the muscle relaxant, would you consider decreasing the dose?
Yeah, you could play around the dose. You could also play around with a different muscle relaxant. There's several different muscle relaxants you can try, some of which tend to be more drowsy than others. I would have her be careful with driving or operating heavy machinery on a muscle relaxant, but it's certainly reasonable to try something else, especially if she's having trouble sleeping because of the back pain. That's a pretty safe time to take a muscle relaxant.
Yeah, awesome. So we have some ideas for her pain. This is quite a bit that we've addressed in this visit so far. And she has one other question. Recently did some Google searching, saw that type 1 diabetes is caused by beta cell failure, thus it needs to be treated with insulin, and she saw that type 2 diabetes is caused by insulin resistance. So she's really curious why she needs to be on insulin as a type 2 diabetic. Mollyanne, what are some reasons why a type 2 diabetic would have to be on insulin?
Yeah, so basically I explain this to patients as, your pancreas doesn't work very well because you have diabetes. And when you're younger and when you're first diagnosed with diabetes, we can give you medicines to help your pancreas work a little bit better, but eventually your pancreas just fails. And we can do all the medicines that help your pancreas work better or help your body process sugar better. But at some point, we just have to give you insulin because your pancreas can't make it very well. It's like, in medical words, we would think of it as like end-stage pancreas disease. And it tends to be patients who are older, patients who have had diabetes for a while. You can keep throwing really good non-insulin meds, but eventually many patients just have to go on insulin. Mm-hmm. And have to, I actually have a similar patient who's about a decade older than this patient, Sam, who really, really refuses to go on insulin. She's scared to death of it because her sister was on insulin and they had really scary episodes with hypoglycemia. And I've been telling her for a year that I'd like to put her on insulin and she won't. And so then we talk about the risk of having your hemoglobin A1C at 10 to 11 is really high. But I can't force you to do anything. And so I present insulin as an option every time she comes to my office. And then we talk about all the other non-insulin things that we can try. And she knows that I can't do very much without starting her on insulin. But patients get to make their own decisions ultimately.
And patient determination is the name of the game in outpatient clinics. They come in healthy. There's little things you can do to help a healthy person feel better. And some of the long-term things that we can do often aren't desired purely because it's something new or something that would be an inconvenience for their perceived well-being. One endocrinologist I listened to discuss this and then also saw some PubMed articles on to verify, basically said that at the point when somebody's diagnosed with type 2 diabetes, they have enough beta cell failure that they're no longer able to compensate for the increased insulin resistance. And so the onset of a type 2 diabetic needing insulin is merely a progression of what was already in place whenever they were diagnosed with diabetes, and that's that their beta cells are failing, either due to a myriad of factors, whether it be glucose toxicity, lipid toxicity, or even just the general senescence that comes from overwork. So Sam, when she's your 10-year-old patient 10 years older patient that you have, how often are you seeing her, and when would you like to see Sam back?
I would see Sam back in a month. She's got a lot going on. And my very similar to Sam patient in real life, I see her once a month pretty much because she's got a lot going on. And actually with COVID, we've done a lot over the phone because my particular patient refuses to leave her house because of COVID, for better or for worse. And some of Sam's management we may be able to do on a telehealth visit as well. That's kind of the blessing and curse of COVID, is it's made us talk about telehealth. And so you could go over fasting sugars over the telephone and coach someone through back pain as well if you've already done a good exam at some point. Or if you haven't done a good exam, but COVID forces you to just do the best you can. So I would definitely see her back in a month, and we covered a lot in Sam's visit. So I would make sure that I kind of do let's talk about what you're going to change before you see me next month, maybe set a goal or have her set a goal of how much she's going to walk, and a new medicine, Voltaren, that she's going to try for her knee. Try to pick out 2 or 3 or 4 changes that you've made. Because probably at this point you've talked about a lot of different things, but Sam may not remember exactly what you said you were going to do.
Yeah, which is another good point of, you can talk about a lot, but you got to make sure that the patient understands and knows what it is that you're talking about. So when you set those goals with the patient, is that the last thing you do in the visit? When do you structure that? Do you put it in your discharge paperwork? How do you make sure that the patient goes home with an understanding of what you and the patient decided on to do in the visit?
I usually do it right before I walk out the room. Kind of go over, this is what goal do you want to set before you see me? I've sent this new medicine to the pharmacy. I'll see you back in a month. Sometimes if I have time in clinic, I'll type it out in the discharge paperwork as well. Sometimes there's not time to do that, but fortunately we do have, we use Epic here, and it generates an after visit summary that will have at least the medication changes on it. And my nurse will often drop some patient education materials into the after visit summary, which for patients who read English at a 6th grade level can be fairly helpful if they look at it.
That's great. All right. So Kelsey, do you want to just highlight some of these teaching points that we have for a couple of take-homes?
Yeah, and I wanted to add one thing too, kind of when we were talking about her difficulties with exercise and all of her pains. I wanted to point out that that's really important in patients with diabetes, because exercise itself has an insulin independent pathway for taking up glucose. And so you really, really want to get patients exercising that have diabetes, because it helps preserve some of that insulin resistance, because they're able to handle that glucose load with an additional pathway, exercise itself, on top of insulin, because they're 2 separate pathways. So kind of wanted to add that. But it's kind of, I'll add that to the teaching points in a second. Yeah. But kind of some of the other highlights of teaching points, metformin is commonly kind of a first place medicine to use for kind of where to start with diabetes treatment. There's evidence that intermittent fasting and carb counting can both improve insulin resistance. Made a lot of points today about being sure to speak in ways that the patient understands, and kind of doing teach back and that sort of thing. And some important follow-up labs for patients with recently diagnosed diabetes can be TSH, BMP, urine microalbumin to creatinine ratio. A1C of 6% is equal to about a fasting blood glucose of 120, and then every 1% increase in A1C correlates to about a 30-point increase in fasting blood glucose. That's kind of a general rule. And there's some things that can falsely elevate or depress A1C. So it can be falsely low if you've lost a lot of your hemoglobin, which makes sense. So that would be like a rapid blood loss, acute anemia, things like that. And it can be falsely elevated if they have red blood cells that essentially are sticking in the circulation too long, And so, for example, if they have splenic issues, because that's how red blood cells are handled. Glimepiride is a sulfonylurea, which mechanism that results in increased release of endogenous insulin. So your patient has to have a good functioning pancreas for that to work. Carries the risk of hypoglycemia, and it is not cardioprotective. And so it can be useful because it's not very expensive, and there are patients that have been treated for a long time that might still be on these, but if their insurance can handle it and financially it's an option, it's better to switch them to one of the drugs that has some mortality benefit. So some examples of those would be GLP-1 agonists, which have weight loss benefit, DPP-4 inhibitors, SGLT2 inhibitors, which those help with weight loss because you're peeing out glucose, but that gives you a risk of UTIs because there's a lot of sugar in the urinary system. There's no hypoglycemia risk with that. But those can be expensive. So there's a lot of options you can reach out on. And then let's see, SGLT2 inhibitors have kind of a theoretical diuretic effect, so that can be helpful for a patient with hypertension. Someone with diabetes that also needs an antihypertensive, ACE inhibitors and ARBs are almost always going to be your good starting point for the antihypertensives, specifically because of the kidney protective effects. A patient that may or may not take their medications on a consistent basis, clonidine might not be a good option for them because there can be some rebound hypertension in patients that stop taking that. So it's very important to just kind of like talk about a patient's day-to-day life, what works well for them. And if the patient has a really irregular schedule, night shift, things shifting a lot, if it's a twice-a-day medicine, you can say when you wake up, when you go to bed, or you can say when you're brushing your teeth, because most people brush their teeth twice a day. So, but it's also good to choose meds that they can take without food, can be okay for them to miss. So just kind of knowing the patient's lifestyle is really important, was a big, just kind of solid discussion point in general. It came up a lot today. And then there's a couple of interesting effects that can kind of affect morning glucose. So the dawn effect is basically saying that cortisol and some other hormones like growth hormone and others rise kind of in the early morning, 2 a.m. to 8 a.m. range. And so those can result in an increased fasting blood glucose. So that's just an important kind of effect to keep in mind. And then I cannot pronounce it, Samaji effect, basically is saying that if there's too much insulin or not enough meal being eaten at night right before bedtime, that can basically cause hypoglycemia overnight, which your liver reacts to and increases cortisol, and that increased cortisol then results in a spike in your morning blood glucose. And so if you decrease that nightly long-acting insulin, that can actually paradoxically bring the morning glucose back down because you're not going to have that cortisol reaction causing the increase in glucose. And then we talked a little bit about pain management. Voltaren gel is a good option for someone that you want to avoid systemic NSAIDs in. So for example, a big one with diabetes would be patients with CKD, because obviously diabetes can affect kidneys. So that'd be a good example of a patient with that. Big quote that came out was motion is lotion, and returning to clinic is another big important thing that we talk about with these patients. You know, how soon do we want to see them again? Are we negotiating treatment plans? Are we going to try really hard to make exercise work before medicine or whatever? So returning to clinic and having really good follow-up can be life-saving and really helping with morbidity and mortality, since kind of how we talked about it being a silent killer. Morbidity and mortality can be really significant in the long run if you're not consistently following up these patients.
Awesome. Thank you, Kelsey. Mollyanne, anything you would like to add or highlight?
Yeah, two thoughts. One is, speaking of interdisciplinary teams, this is a good place to pull in if you have a pharmacist embedded in your clinic. They can often do some, like, let's talk about how your diabetes management is going with the patient. My clinic has that, and the pharmacist will call the patient and go over fasting sugars and are you taking your meds and stuff like that. A dietitian as well can be very helpful for diabetes management, especially someone that is needs to know how to carb count if they're going to be carb counting to prevent developing diabetes, or adjusting their mealtime insulin based on carbs. And then the other is, diabetes with hyperglycemia kills you in the long run, but hypoglycemia kills you in the really fast. And so especially patients on insulin, You always need to, like every clinic visit, have a discussion of, have you had episodes of hypoglycemia? How did you feel? What did you do? What are the symptoms? And really encourage patients, if they start to get the symptoms of like feeling cold and clammy or sweaty, feeling shaky, feeling like something is wrong. If you've got your meter with you, check your glucose. If you don't, eat something anyway. And like, it is an emergency. This can kill you. Really having those conversations with patients that are life-saving, because hypoglycemia is really, really dangerous.
Awesome.
A fun pearl to go with that is if a patient is also on a beta blocker, they might not have some of those symptoms. And so sometimes sweating is the only one that shows up with them. So if they're on beta blocker, super important with that.
Cool. Thank you all. All I have to add is that I often think about diabetes as having a trident of treatment. You have diet, you have exercise, and you have medications. And the more we can shunt people towards the first two prongs of diet and exercise, maybe the more likely they'll be to comply. And also the better off they'll be in the long run. They'll avoid all the medication side effects. So with that, we will close. Thank you so much for being part of this discussion tonight. Thank you, Mollyanne, for joining us, and Kelsey for scribing. Have a good night, everybody.